Good evening, everybody. On behalf of Brinton Pharmaceuticals, I, Ashwin Kotamkar, welcome you all for today's webinar, Acne, the Everyday Issues. We all know that every patient is different and every patient needs different treatment. Same is with acne. Acne is one of the very serious disease which is difficult to treat in dermatology. And for that, we have with us 5 eminent dermatologists of India: Dr. Sanjeev Handa, Dr. Sanjay Ghosh, Dr. Satish Udare, Dr. D.A. Satish, and Dr. Rahul Mahajan, who will discuss acne, the everyday issues with us today. Before we start today's program, I request Director of Brinton Pharmaceuticals, Mr. Vijay Christopher, to please address the gathering.
Thank you, Dr. Ashwin. As the man built a better mousetrap, the nature built a better mouse. This war of our mankind against the virus has been going on for many centuries. I am sure and pray to God that He should be with us this time also and help us win this battle against COVID-19. Good evening, respected members of the medical fraternity. I am Vijay Christopher from Team Brinton. At the outset, I would like to pay my huge respects and regards to all of you, the COVID warriors, who are relentlessly working and protecting us while we are staying safe indoors. Once again, please accept our huge respects and appreciations to all of you. Brinton is very proud and honored to host today's webinar. The topic being acne, the everyday issues. Today we have a galaxy of stars. You call it as stars, you call it as exponents, you call it as international players amongst us. It's my proud privilege to welcome the moderator for this evening, respected Dr. Sanjeev Handa, the head of the department from PGI Chandigarh, and the 4 eminent panelists, respected Dr. Sanjay Ghosh from Kolkata, respected Dr. Satish Udare from Mumbai, respected Dr. D.A. Satish from Bangalore, and as well as respected Dr. Rahul Mahajan from PGI Chandigarh. Now over to Dr. Ashwin.
Thank you, sir. Thank you for the kind words. Now I call upon our moderator for the session today, Dr. Sanjeev Handa. Dr. Sanjeev Handa is having more than 30 years of postgraduate teaching experience at PGI Chandigarh. Dr. Handa is having 250 publications and 17 citations in Rook's textbook of dermatology. And he is a renowned faculty at 30 international and 70 national conferences. Dr. Handa is a task force member of EADV group for autoimmune bullous diseases. Respected sir, I now hand over the session to you.
Thank you, Ashwin. Good evening, friends. It's my pleasure to be moderating a session on acne today. And I have the pleasant duty of first introducing my panelists to all of my viewers. And I have the pleasure of introducing Dr. Sanjay Ghosh to you, who is former professor and head MGM Medical College and presently the director at IAISD Calcutta. Sanjay, can you just wave so that people know that you are there?
Yes.
Yeah.
Yes.
And
yes, I'm here. Very much.
Yeah, our next panelist is Dr. Satish Udare, who is a senior consultant dermatologist practicing in Navi Mumbai, Thane for the last 35 years. And I also have the pleasure of having with us Dr. D.A. Satish, who is a senior consultant dermatologist practicing at Sagar Hospitals in Bangalore. And lastly, I have Dr. Rahul Mahajan, who is an associate professor in my own department here with me today. Well, friends, we go on to the actual discussion for today. We've all heard a lot about acne on different webinars. We keep reading about it because of different articles in various journals over the times. Today, we've chosen a little offbeat areas for you, areas which we do not discuss that commonly, that is especially pediatric acne, and also areas which are a little ticklish, that is acne in women, in adult female acne. These are some of the articles which came recently and make for interesting reading. Those of you who are interested in acne management should go through them. So we'll basically look at why do we really basically need to work on acne? The reason is that it is one of the most prevalent diseases in the world, so to say, 8th in number, and there are around 650 million people globally. That means almost 9% of the population, which is a huge number. And it affects more than 80% of adolescents. The disease is associated with scarring, both physical as well as psychological. And this results in loss of confidence, depression, and suicidal ideation. And it affects the quality of life. And in that, it is comparable to chronic diseases like asthma, seizures, and diabetes. Now, starting with the actual panel discussion, I'd like to request Dr. Satish to take up this question. What history do you take, Satish, when you first encounter a patient in your clinic?
Yeah, thanks, Sanjeev. I think I think you are asking me about the adolescent and adult acne.
Yeah, you could just frame it as a general history taking that you do for your patients of acne, Satish, without it being specific, because there are some pointers that I would like you to bring up for our audience today. You feel comfortable, whichever specific group you can take up that. There is no issue.
The duration, we start off with the duration of acne and the type of lesions the patient has noticed, the progression, family history, genetics, diet history, menstrual cycle, treatment taken so far and the response to treatment, and variations with season. And also, I think these are some of the factors which we have to
Satish, do you normally ask people about other body part involvement when you take their history, or do you take it as a part of the examination, or do they volunteer? What is your experience?
Most of the time when they have it on the trunk, unless it's severe, they don't volunteer.
Yeah, precisely. That's a point which I wanted to highlight for my audience today, that unless you ask somebody to lift up the shirt and show you the trunk, that part may not be volunteered by a patient. That's important, actually. Yeah. Go on, Satish.
Yeah, and that's some of the history which we take. And well, you want me to tell about the examination also?
No, that will come to that later. Okay, now I'd like to ask Dr. Udare something. Dr. Udare, what do you think is one of the most important determinant in your treatment plan?
Sir, I would like to add up initially to Dr. Satish's points of history. You know, the cosmetic use, the cosmetic procedures done, because there are so many people, especially ladies, who come with acne suddenly, where they have used recent cosmetics or have done a cosmetic procedures, including our procedures such as laser hair removal, which can give rise to acne. So if they don't come out with this kind of history, it is difficult to predict and ultimately treat. Once you have got the proper...
That's a lovely point. That's a lovely point, Dr. Udare. A history of prior procedures that the patient has undergone. I think that's a lovely... And one more aspect there I would add is occupation of a patient is very important.
I was coming to that because basically in this case, we'll have to ask about the occupation, not only the occupation, the other drugs which the patient has taken. Like Dr. Satish told us what previous treatment has been taken and its effects and all those things. But there will be other medications patient is on. And then our setup, basically Indian setup, anti-cox treatment, I think we should harp on. Because that is one thing which can give rise to acne from eruptions.
Dr. Udare, the basic idea of asking a very basic question here in the webinar of history taking, my intention was to bring up points which are very important in ultimately managing a patient. So unless that part is done well, as they say, well begun is half done. So it's like that. If we do not do that, then we don't. Sanjay, I have a question for you.
Sanjay, can I add a bit?
Yeah, sure, you can.
Sanjay, can I add something on the history?
Yes, Sanjay, you can. Please go ahead.
Actually, in the history, occupation, as you have told, occupation is important in two aspects. First part is that if a person is working or lady is working in the film or television, so then even it is a mild acne, we have to do some stronger treatment. That's important. And number two, occupation also important for the acne development, because some greasy environment, that occupation can lead to acne. So these two parts in the occupation. And another very important part of history, I think, is the psychological aspect. We have to first, when we are first encountering a patient, we should know the psychological status, because if a patient with mild acne, she or he may have serious say lack of confidence. So there we go for the higher treatment, not very simple treatment.
And probably those are the patients, Sanjay, who would probably need a little more than our intervention alone. We may need to bring in our psychologist friends as well. Yes. Sanjay, I have another question for you. Do you investigate all patients of acne as they come to you, irrespective of the type of acne? Do you normally do it when you begin your management?
No, it is not needed. But if the patient has lady and have menstrual disorder, or if sign of any hyperandrogenism, I go for the test. And
all right. We'll take that up later.
If I suspect gram-negative folliculitis, I can do a test. And also, before starting any medicine, especially isotretnoin, you should do some investigation.
Okay, that's great. We all know about the etiology of acne. We know that it's multifactorial, and there are four basic, the conventional teaching has been that there are four basic things that we need to consider. One is increased sebum production, the other is epithelial hyperkeratinization, and third is the Propionibacterium acnes proliferation, and also inflammation because of the release of mediators. I'd like to ask Dr. Rahul a question. Is there something new in the etiopathogenesis of acne that we need to highlight with our viewers?
I won't say it is dramatically new, because these four things that you mentioned just now, they still form the backbone of acne pathogenesis, but there has been incremental increase in our knowledge about acne. For example, the emphasis on microbiome. There is a lot more emphasis on microbiome now, these days, and there are trials now which are focusing specifically on the streptococcus or other aspects of microbiome.
So can I add a little bit, Sanjeev?
Yes, Sanjay.
So about the newer thing, apart from the androgen, what we are thinking is the main culprit. Nowadays, the insulin-like growth factor or insulin-like growth factor 1 is a very important thing in the pathogenesis of acne. And number two, innate immunity. That's why innate immunity, especially toll-like receptor 2, is important in the formation of scarring. Immediate inflammation, robust inflammation causing scarring. So
that's a very good point that you brought out about insulin-like growth factors and their role in acne. That is the area of research which is taking off more and more now, and probably will determine our treatments later. If we come to the clinical pictures that we see of acne, we have the classical mild acne, then we have the moderate acne, and then we have the severe acne. And for today's discussion, we will be taking up not the usual cases, but we will be taking one by one these clinical scenarios, of which I'm going to start with pediatric acne first. And this pediatric acne Dr. Satish, can you give me an idea as to how pediatric acne is actually divided up?
I think the commonest, which everyone sees, is the neonatal acne, which starts usually at around 2 weeks and may go on up to 6 weeks. Then we have the infantile acne, which can go on up to a year or so. Then we have the mid-childhood one, which is say 1 to 7 years, as we have put it off. And we have the pre-pubertal acne or the pre-adolescent acne, 7 to 12 years. That's generally how the pediatric acne is classified in.
Yeah. Dr. Udare, if I may ask you, out of these, how often do you see any one of these? I mean to say, which, as per you, is the commonest that you encounter?
Neonatal acne.
Neonatal.
Okay. And what exactly do you see in neonatal acne? Is the distribution and morphology of neonatal acne distinct?
It usually comes on the cheeks and sometimes on the forehead. These are the typical size, and most of the lesions are comedons. Inflammatory lesions and pustules and this thing usually I don't see. It's only the comedons which are and for that matter, when we tell the mother that these are acne, she gets surprised. Oh, my baby getting acne at this stage. So these are little ones, and then another thing.
So what is that? What is that little bit of counseling that you do, Dr. Odare? That is it something to worry about? Is the treatment
so the
difficult?
most important thing to tell the patient's mother and parents that basically this is something which happens in quite a few young babies. It is because the hormones which are there, some coming from maternal, so some coming from the baby. The habits in massage, apply a lot of powders and other thing on the body. So to avoid that, just relax about it, and most of the things goes by itself. Don't have to worry about it. It is nothing serious about it.
Rahul, can I ask you something? Do you have any differential diagnosis when you see patients of acne? Does something cross your mind which you would like to make our viewers a little aware of?
So as Dr. Odare said, so although it can be quite typical presentation, we still have common dermatosis, which present in the neonatal phase, and sometimes slightly beyond the neonatal time also, beyond 4 weeks also. You have benign cephalic pustulosis, which typically has pustules in it, and then you have some apart from you can have simple staphylococcal or streptococcal infections of the sweat glands also. These are quite common during this phase also. So it's not uncommon to have a clinical picture which is very similar to neonatal acne, but typically it lacks the comedones.
Okay, and what exactly is thought of as the cause for the neonatal cephalic pustulosis? Do you think that's still a distinct entity, or does it somewhere the semantics is still questionable?
It's like what is in the name, as it's a very famous quote. What is the name is in the name. So whether we call it benign cephalic pustulosis or we call it neonatal acne, we like to, as dermatologists, we like to have a threadbare discussion on everything. So comedones or lack of comedones, sometimes it is a distinguishing feature, but as many people consider these whether it is benign cephalic pustulosis or it is neonatal acne as a continuation of the same thing, because both of these are going to resolve very soon. Even transient macular pustulosis, it also is considered one of the differentials. It resolves.
Dr. Sanjay, I have a question for you.
Yes.
Sanjay, in case a patient...
Before that, just I want to add about this cephalic pustulosis. There is speculation that, and also it is proved that Malassezia farfar is sometimes is the cause, and giving topical ketoconazole give the good results in this. And there is no comedone, so chances of I think it should be a distinct entity rather than a neonatal acne. Okay, your question.
Usually more papules.
Yes, pustules is more common here, which is not common is neonatal acne. There comedones we don't see. Mostly we see pustules.
I would agree with you, Sanjay. There are a lot of people still who tend to differentiate between the two conditions and believe that neonatal cephalic pustulosis will improve with antifungal treatment as for Malassezia, while neonatal acne may not. As Rahul said, if there are comedones, you may still need to use a little bit of benzoyl peroxide as a management guideline.
I do believe also that.
Yeah, Sanjay, I would like to ask you a question. In case a patient who's that small and is not responding to treatment, what exactly do you look for? Do you check for any physical signs? What exactly do you do?
Yes. Now, if it is little more inflamed, another we can try with this some even systemic antibiotic like erythromycin or cephalexin like that. But if it is a very recalcitrant, not respond to topical and the systemic antibiotic, we can think of definitely neonatal acne. It's less common. In infantile acne, it's much more common that there will be chances of some increased hyperandrogenism. This chances of hyperandrogenism.
That's the point I wanted. That's the point I wanted you to make. Actually, Sanjay, that's absolutely the point I wanted you to make. And the other issue which in that age group, I would like all my viewers to have a take-home message is that we have to consider either virilizing tumors or congenital adrenal hyperplasia as a possible diagnosis if you have that small a child who is having recalcitrant acne.
Yeah,
So that's something which I would like them to go home with. And
that is typically the case in infantile more than neonatal.
it is more common in infantile rather than this neonatal one. Yes.
Yes. This is for you, Dr. Udare, again. In the infantile acne that you see, do you feel that is infantile acne that is occurring a poor prognosis for future? Do you think like that? Does infantile acne actually imply a poor prognosis?
We will keep it in our mind, these things that these people may get acne when they grow up. If you tell them right at the onset to the parent that isko baad mein bhi aane wala hai, the mother is going to start crying right in the front of
all
you.
Right.
So basically, keep that in your mind. Yes, this person is likely to get acne when he grows up, but I usually keep it in my mind.
All right. And may I ask, what is the opinion of my other panelists? What do they think that does it imply normally a poorer prognosis for future that yes, the child is likely to have acne when he or she grows up?
Yes, possibly. Yes, there is some evidence to support that. But then possibly there aren't sufficient long-term prospective studies to really conclusively say. But yes, there is evidence to say that people who have severe acne in adulthood, they might have had infantile acne or severe infantile acne.
Yeah.
Sanjeev, there is one common cause of this acne in neonates and infants in India. That is a lot of oil massage which they do.
That is what I said.
Yeah, on the face.
Yes.
Okay, that's very common cause. And sometimes even any rash on the face, a topical steroid is applied. So when we are looking into this problem, we have to look at these two aspects also. And majority of these children, this spontaneously, it regresses. So I think that's counseling is very important for the parents.
Well, there are a couple of...
Sanjeev, just one thing. Sanjeev, one recent report that especially the infantile acne we are getting more nowadays, your use of topical androgen by their parent, particularly their father, they are using for different increasing libido or sometimes for hypogonadism. That contact in sometimes in increasing this infantile acne. Though there are certain reports in the journals.
Okay, anybody would like to comment on that? Okay, can we Sanjay, you talked about recalcitrant cases and investigating those people. Yes. Do you normally go through all these tests or for children who have recalcitrant acne?
No, not all. I particularly do DHEA. That's first one, and testosterone. That's total free testosterone ideally, or sometimes total testosterone, and sometimes 17-alpha hydroxyprogesterone. So this I do if I suspect there is chances of hyperandrogenism. But if it's a refractory case, I take help from my endocrinologist friend, and if they advise, I do the whole battery of tests.
Yeah, so my message to all my viewers would be that if you have persistent acne in children, remember that it may be an indicator of possible underlying endocrinopathy. That's something which we would like to have all of you take as a carry home message.
Especially sometimes we tend to miss the 17-alpha hydroxyprogesterone.
Yes,
because it has adrenal origin. So especially in adults also, we concentrate on FSH-LH ratio that will be coming on later also. But 17-alpha hydroxyprogesterone is a very important investigation for congenital adrenal hyperplasia.
Yeah, Dr. Udare, can I ask you something? That when you have a child being treated with infantile acne, what do you think is the time that you need to give systemic therapy in these children? And if yes, which drugs do you prefer to give?
If at all, basically, I would give it at least a month's time see all that. He is not applying anything, especially oil, as Dr. Satish has said. Basically, next thing I would give systemic little bit of antibiotics, erythromycin. I would prefer.
So out of the antibiotics, your choice would be erythromycin. Anybody else would like to use something else in these children?
I would prefer azithromycin, Sanjeev.
Cephalexin can be used.
Azithromycin.
Cephalexin also can be used.
All right. Rahul, would you like to say something here?
Yeah, topicals maybe after the other things that have already been mentioned, that avoidance of excessive oil or occlusive atmosphere. So topical benzoyl peroxide is perhaps still the drug of choice, because it is.
I would like to ask you, Rahul, do you think children can be given retinoids? Because many a times the conventional teaching always has been that you do not give retinoids to children.
No. I mean, we have been giving retinoids and in a fairly high dose for all the kids with ichthyosis. So why not for infants who have severe enough acne?
No, when there is scarring.
No, but may I ask something? What do you mean by severe, and what do you mean by uncontrollable? What is the time limit you're going to give? Because you're going to give you something more. What I would really worried is the bone complications of the isotretnoin. Ichthyosis is something different ballgame altogether, and acne is something different ballgame together. So when you will consider?
With due respect, I partly agree with Dr. Vadare. So we start with.
Rahul, you have to speak loudly. We can't hear you.
So I partly agree with Dr. Vadare, but we start with the topicals only, benzoyl peroxide or topical retinoids. But once maybe after 6 weeks of topical therapy, if the chances, the frequency of such severe acne in infants will be, it's not uncommon, it's rare. But if needed, based on the physicians or the dermatologist examination, if it is severe nodulocystic acne in an infant or in a young child, one can definitely go for oral isotretnoin. There is no harm. I mean, we examine the child with biochemistry evaluation and once a year X-rays, but it's pretty safe. And these are there in the guidelines also.
Well, we have a couple of audience questions which I would like to take up. Dr. Sanjeev Chaudhary has asked a question: is there any gender ratio of neonatal acne? Like, is it more in
boys?
Yeah. Sanjay, you would like to take that up?
I'm taking, this is a male. Actually, male are, boys are more affected. The reason is there because it is that it is speculated that the infantile testicles are producing more androgen, ultimately stimulating the adrenal to produce more androgen. So this is one reason why these boys are more affected. There is a testicle secretion of androgen.
And somebody is also questioned about periporitis being a differential diagnosis for infantile acne. Rahul, would you agree to that?
Yes, any pustule on the forehead would one might think of, but again it lacks comedones. So periporitis, we know it will have fairly big. Many times it has big pustules which are difficult to miss. But yes, as a part of pustule, you can keep it differential. But as dermatologists, we are able to differentiate it.
Dr. Satish, there is a question which has come up from Dr. Indranath Mishra, who wants to know, in pediatric acne, often dermatologists diagnose it with the atopic background. Do you agree?
I don't think so, because it can occur in any child. There need not be an atopic background in all individuals. Right? I have seen patients, children without atopic also.
All right.
Can I add something, Sanjeev?
Yeah.
Just one thing. Atopic may have more acne. The reason could be the topical emollients which are putting by this atopic patient. This can be have comedogenic product.
Sometimes the use of
acne or steroid abuse. Or steroid abuse.
Absolutely. Sometimes the use of emollients for dryness, and then also if you overuse in a certain climatic condition, you may end up with acneiform lesions. I would agree with you there, Sanjay, totally. Like, moving on to pre-adolescent acne, or I would like to first ask a question, Rahul, to you. Out of the types of pediatric acne, which acne alarms you when it comes, and why?
basically the mid-childhood or the infantile acne.
Absolutely. Because this question I'm asking is partly overlapping with the comment which Sanjay made about hyperandrogenism. So mid-childhood acne, if we are seeing, because at that time we are not supposed to be having any adrenal activity and others, should be a cause of worry.
Less between 1 to 7 years of age. That
Yes,
could be the,
yes.
Yes.
Yeah, yeah. And coming to pre-adolescent acne, which other conditions would you like to consider for pre-adolescent acne, underlying conditions I'm talking about, Rahul?
it's the same set of conditions that we initially also thought. I mean, basically, we go for a detailed physical examination first. If there is, if the child has already attaining any features of precocious puberty, if there are any virilizing signs and symptoms, and then we think maybe if there is hoarseness of voice, we think of congenital adrenal hyperplasia. If they are falling episodes, you mean there may be some mineralocorticoid hyperactivity. So those are the things that would come to mind.
Yeah, well, moving on to the next part of our discussion for today, that is severe acne. I'd like to ask Dr. Udare. Dr. Udare, you see severe acne in your practice. And what is your take on the use of antibiotics for severe acne as of now, and considering the different guidelines that come in?
Basically, severe acne, nodulocystic, the infection is definitely there. Propionibacterium are causing havoc, and some sort of antibiotics, locally as well as systemically, both I would like to give the same group of antibiotics. Definitely not too long, but they are definite additives. And considering the recent reports about the resistance which have antibiotics developing, along with benzyl peroxide is the most important thing I would consider.
All right. And if you are giving antibiotics, Dr. Udare, which antibiotics do you prefer?
My most favorite antibiotics is doxycycline. Though I would love to give basically azithromycin, but with recent reports and azithromycin being an important drug, I have kept it as resort. The first drug I would give is doxycycline. Minocycline, I'm a little scared about because of its side effect profile.
Satish, can I ask you which antibiotic do you prefer? My first choice is always doxycycline. And I give it for say about approximately 8 weeks. Previously, I used to give it for about 12 weeks. Now I have reduced the duration. And it's very important that the antibiotics are used judiciously, and the patient does not allow the patient to take it by themselves.
That's actually a very important message.
Yeah.
And do you normally combine these with other drugs?
Yeah, I always avoid topical antibiotics.
Always. I would stress on that word always, because monotherapy with antibiotics, either topical or oral, is a big no-no for management of acne now.
And also add benzoyl peroxide topically to delay the resistance or prevent resistance.
Yeah, amongst the panelists, I would like to ask, does anybody have an experience with limecycline?
Yes. Yes, I do have. Yes, I do have. Presently, I'm preferring this drug because the doxycycline, we know photosensitivity is there. And minocycline we have used, also have seen PIH is more common. Pigmentation is more common with minocycline, and that's sometimes difficult to erase. So this limecycline has not that side effect, no photosensitivity and no PIH. And also the limecycline I've seen toleration is good. Only it is cost. So those patients can afford. I'm choosing limecycline for this. And that is a good drug. And it is more soluble, and that is it is absorbed by active transport, so absorption is good.
Any personal experience, Sanjay, of having used trimethoprim or cotrimoxazole?
No, I don't like this because there is not much data on this particular drug. Only it is sparingly used, and it is not approved that way. And as we know all those side effects of this trimethoprim, so I'm not very eager to use it. Only it could be reserved for those who cannot use for tetracycline, but I have no personal experience.
All right. Moving on, I have a question for Dr. Udare again. if you've given systemic antibiotics, Dr. Udare, and there is a failure of antibiotic therapy, what would you like to do then?
First of all, monotherapy, as we have already said, we are not going to give. So whether right from the beginning it will be a combined therapy. In the combined therapy, definitely it may not be the only effect of failure of antibiotic. It may be something else altogether. So these are the patients I would investigate and find out other causes, take little more history, and basically again I would harp on the compliance part of it, whether they are really taking drugs or not. Because whatever said, the major problem of acne therapy failure is the compliance by the patient. Adherence is one thing which I'm scared of. They take it for some time because of the cost, because of the side effects, or because of some reason best known to them, they stop the medications. And these are the things I would harp on.
Yeah, there are certain set prescribing policies which are used in all guidelines to avoid resistance, and I would recommend all my viewers to go through those in order to avoid antibiotic resistance coming in even more. Rahul, would you like to add anything quickly on this?
Yes, emphasizing the same thing, that topical benzoyl peroxide or topical retinoids need to be added, like adapalene or along with, if and when we consider giving oral antibiotics, these things need to be added along with the oral antibiotics, because in the end you are going to maintain with these agents only, and obviously these prevent the development of resistance, and never to go beyond 16 weeks. Dr. Satish, I think, said, Dr. Ghosh said 8 weeks. 8 weeks is very ideal. Absolutely correct. But never beyond 16 weeks.
A point well made, Rahul. And I'd like to take up another audience question, which actually relates to acne and the current COVID scenario. This, any one of my panelists can take it up. This is again from Dr. Sanjeev Chaudhary, and he wants to know what is the advice regarding increased incidence of acneiform eruptions with the constant use of masks, especially for those wearing the PPE kit for prolonged periods.
Yes, that has been something which has been of concern with our colleagues also, who are, they have to use PP for at least six hours at a stretch, and during that time they are just not, they cannot do anything except for being there in a very difficult circumstance. And so the pressure of the mask, it is put on the nose, and you have sweating also, and so many factors that are going on inside that PPE kit. So adequate hydration of the cleansing of, before you put on your PPE, if you can wash your face with a good pH balanced cleanser, and once you take it off, you again wash it with either with the pH balanced cleanser or apply a moisturizer, because some degree of skin damage or epidermal barrier dysfunction is going to occur while you are wearing the PP. So maintaining your routine hygiene.
Rahul, any comments on the contact eczema part? You know my fondness for contact eczema, and Sanjay also is another one of our panelists who is fond of contact eczema. So do you think that may have a bearing on this question as well?
Exactly. Actually, I think COVID is going to increase dermatological practice. I think COVID is going down and dermatology practice will increase. Now some dermatologists are losing due to non-practice. I think it will be by contact. We are already getting a lot of irritant dermatitis of hand due to repeated washing up with soaps and others. And this is another factor what Sanjeev has told, that this PPE and the mask, so that any occlusion we know can increase acne. So we have to use the dry if possible, because PP not possible to remove. So when there's removing, they should dry it with dry cotton first before cleansing, and face also drying that actually this accumulated sebum should be removed. So I think it is.
Yes.
Yeah, I've seen folliculitis and furuncle on the nose in people who are wearing masks for a long time.
Yes.
Long durations of time, right? But till now, I have not seen acne.
Acne has been reported with the use of masks for the previous H1N1 episodes that have taken place. And that's been because of 2-3 things that have been described. Certain chemicals that are involved in the process of making of the masks. And there is an interesting question which has been brought up by one of our viewers, Dr. Shreyas, and she has asked what could be the cause of unilateral facial acne. She wants to know about the causes of unilateral facial acne. Would any of my panelists like to take it up?
Most important cause is pressure and friction again.
Yes.
The mask. Basically, you'll have to really go into the history of patients' habits and patients' whether there are typical examples. If somebody is playing sitar and gets acne over there, somebody who's basically habit of studying with their cheek, hand on the cheek. So basically, all those friction and all those things, detailed history should be taken to get answer to that. Otherwise, there is no internal reason for that.
I may add, sir, like 2020 may be the year of COVID pandemic, but dermatologists have been facing this tinea epidemic for the last 5 years now. So once you see a unilateral pustular eruption, apart from thinking of acne, one should definitely think of maybe steroid modified tinea. And another reason for unilaterality could be sometimes the patients, if they have unilateral paralysis of one side of the face, they may also develop just the unilateral acne. So that may be one of the
there are a couple of quick audience questions again. Two very interesting questions have been asked. One is by Dr. Anshul Kaul, who has asked whether the dose of doxycycline, Sanjay, can I address it to you, whether the dose that you use is 40 milligram or 100 milligram, and what about combining doxycycline with isotretnoin, although not recommended due to the risk of pseudotumor cerebri?
Doxycycline, there is some use of lower dose 50 mg, but that is nowadays discouraged because that is anti-inflammatory role of doxycycline. But nowadays it is discouraged because there's chances of bacterial resistance. So always it should be used in 100 mg dose. But one condition where you cannot give isotretnoin, but it's severe nodular acne or cystic acne, or then you can give 200 milligram of doxycycline. But I am never promoting or never advising of combining doxycycline or isotretnoin. As it is pharmacologically, it is a incompatible combination, and as the chances of, I have seen patients taking both severe headache and ultimately pseudocytoma. I think better not to use any doxycycline with isotretinoin.
A quick question for you, Rahul. Dr. Rajesh has asked how to deal with acneiform eruptions. I think his question basically pertains to acneiform drug eruptions. Can you quickly answer that before we move on to isotretinoin use?
So once we have identified the causative agent, so if it is a short duration of steroids that has been taken and led to acneiform eruption, just this stoppage of the incriminating agent is many times resolves the acneiform eruption also.
Absolutely.
But topical benzoyl peroxide again becomes, whenever feasible, should be started off with benzoyl peroxide. If it is severe enough, we can give a very short course of oral doxycycline. Nothing more than that.
I'd like to ask Dr. Satish a question now. Satish, do you take written consent before starting isotretinoin?
No, Sanjeev, I don't take consent, but I inform the patient about the side effects, especially the pregnancy-related side effects, and choose the patient properly. Though ideally we are supposed to take consent, I should agree that in clinical practice I'm not doing so till now.
All right.
One thing I do additionally, on the paper, you write down this thing that pregnancy risk has been explained to the patient.
Exactly. Yeah, that's a very important point actually, because in India we do not seem to have that system of I pledge. If we consider that people all across the globe use that system, I think we should probably encourage more and more dermatologists practicing to be very careful about that, because I have experienced this with the use of acitretin in a patient who went on and conceived. And you may say that acitretin may not be given, but I had run out of my options. And that was something which left me dumbfounded in spite of having explained everything, and made me realize that there is a subset of patients for whom we may need to take a written consent. And the other questions I would like to ask is to my panelists. I can ask Sanjay. I seem to have lost Sanjay here on my screen. Sanjay, which are the investigations? Yeah, there. Yeah, Sanjay, which are the investigations you do before you start isotretinoin? Something special that you focus on?
Yes, definitely. First, I do lipid profile, LFT, and blood routine test, and also urea creatinine. Actually, this is a baseline test. Without that, I never start. And after that, every month, first to 6 months, I do this test. And after that, I can do later on, but this I do must. Because in the baseline in our Indian patient, I've seen lipid abnormality is very common, even in the younger age group. So some doctors, without doing this test, baseline test, start it, and after 2 weeks, 3 weeks, the lipid triglyceride goes shoot up high. So I think we should have caution that we should do the baseline test.
Another question on the same line, Sanjay. If you have a patient whose lipid levels start rising once you start isotretinoin, do you use that to stop the drug, or do you do something else? What's your guideline for people?
If the baseline is okay after starting, I've seen a lot of patients after isotretinoin or other retinoid, I've seen it is shooting up. So I start atorvastatin or rosuvastatin, and after that I've seen it is a control. So I carry on with these both drugs. But if it is still not controlled, then I stop it. Otherwise, I don't stop.
Sanjeev?
Okay, Dr. Udare, do you? Yeah, Dr. Satish, you want to say something? Yeah.
I would not do entire lipid profile. I'll do only serum triglycerides and liver functions. And if the patient requires, I will start the patient on fenofibrate also to bring down the triglyceride levels. Surprisingly, I have found that a lot of patients, young patients with a family history of hypertriglyceridemia have been able.
All right. Rahul, your take on that. Plus, I would like to ask you, Rahul, how do you give...
at a very young age, in the early 20s.
Yeah, Rahul, your take on that. Plus, I would like to ask you, how do you give isotretinoin? Any special advice that you give to people?
Yes, so isotretinoin is a very wonderful drug, but it has to be used judiciously. So we go for these routine tests, but the important thing, as already mentioned just now, is the levels of triglycerides. So even if the triglyceride levels, the total cholesterol or the LDL levels may not change much with isotretinoin, but it's the triglyceride levels which might shoot up, or which need to be monitored more closely. And initially, the lifestyle modifications before giving fibrates or statins. Statins may not be of that much of help as compared to fibrates, but before that, lifestyle modifications, weight reduction, the dietary modification, they are really helpful in decreasing the triglyceride compared to any drug therapy. And
yeah, Dr. Udare, can I ask you something? What is the maximum dose, or I would say / duration that you have used isotretinoin for? There is a lot of hype on cumulative dose of isotretinoin, which I think doesn't make any sense to me at all. Means it's
to me, it definitely doesn't make any difference, because basically patients who are going to improve, they are going to improve in very short time. Then 1/3 of them are lost to follow because they have improved. 1/3 of them say we have done better and come back with relapses.
Would you say your management is response based or duration based?
Mine is response based.
Yeah, absolutely. That's the take home message I would like to have all my viewers, that the treatment with isotretinoin should be response based, taking care that you normally don't exceed the doses which are recommended. Normally we don't do that. That's another question which I have for my panelists. How many of you really go up to the recommended dose? Do you ever feel the need to do that? Or is low dose isotretinoin good enough? Yes, Sanjay, tell me.
Can I take Sanjeev?
Yeah, Sanjeev, please, Sanjay.
Actually, I personally do prefer lower dose to start, because I don't believe in the cumulative dose. That is a controversial thing. So after that, if the patient can tolerate and the patient demands, I continue. But there are certain written data that is showing that after, when the acne is controlled, after that 2 months treatment is required, that will prevent the relapse. So that I do follow. After control, I continue up to another 2 months.
So my next question actually was this, that do you taper and stop or do you suddenly stop? So Satish, would you like to take that up?
Yeah, and first thing, I don't believe in the low dose. I always give at least 40 milligram per day. That's 20 milligram twice daily, minimum 3 months. Sometimes I go up to 6 months too. And most of the times I don't taper. I just stop it because I'm very happy with the improvement seen in the patient.
Satish, are you happy with the photosensitivity or the cheilitis which these patients come back with? Because that's the problem which I find when I go to high doses. I am not able to continue isotretinoin because of a lot of issues with their lips cracking and fissuring.
No, that can be easily managed with hourly applications of lip moisturizers. And that's not a problem in my practice. Because why I give the standard dose of 20 to 40 milligram is the recurrence and relapse rates are very less. If you give a very
All right.
small dose to start off,
Okay,
then the relapse rates
quickly
are quite
moving
big.
on. Yeah, thank you, Satish, for that. Quickly moving on. What if we cannot give isotretinoin? What choices do we have? Rahul, would you like to take it up?
Yes, so there has been some data regarding that also, that if you can't give isotretinoin, you can combine oral doxycycline with topical benzoyl peroxide plus doxycycline, topical adapalene plus benzoyl peroxide. So even here, maybe it's not right now available in India, or maybe it's marketed by just one or two pharmacies. Generally, we use 0.1% of adapalene in our formulations. But if we increase that to 0.3%, it really increases the efficacy of topical adapalene plus benzoyl peroxide combination. So using...
Yeah, Dr. Udare, you want to say something? You want to add to that?
Yeah, if the pregnancy is not the contraindication, then another thing which was this good thing is short contact tazarotene. Used to work very well. And there is a new formulation coming up with
an audience
tazarotene.
question which I need to... There is an audience question which I need to take up, Dr. Udare, if you can answer that, or Rahul, anyone. According to the guidelines, the question is currently 1 month of contraception is sufficient post stopping isotretinoin. But in clinical practice, what is the ideal time for contraception? This is post stopping isotretinoin.
You know, I think it is always better. You know, in fact, I have got two patients who, in spite of all these things, in spite of pledge and in spite of making this thing, two patients became pregnant. It was a precious baby, so we continued, and there was continuous sonography and nothing happened. But all the same, if at all I have given isotretinoin, I tell them right in the beginning 6 months. Though it is 1 month nowadays,
absolutely,
you are not going to become pregnant for 6 months. Whatever little amount, I don't want to take any chance.
I think that answers one of the questions by Dr. Maria Rupani, who is asked for how long isotretinoin can be prescribed. So I think all of us in our clinical practice normally give it from anywhere between 6 months to almost a year.
Yes.
Yeah. Yeah. Okay. I think. Yeah. Yeah. Okay. We can move on to the next area that we would like to take up today. That is adult female acne. And we have in adult female acne which may be persistent, and then it may be even late onset. So which are the classical areas, Satish, that are involved in adult female acne for people to make a clinical diagnosis that, okay, this is adult acne or late acne? Yeah.
Both in persistent and late onset acne, the commonal sites which are indicated are the lower half of the face, especially the jawline, chin, neck, and also the severity of the acne is also more. You can also see acne all over the face, sometimes on the trunk also. But predominantly, whenever there is jawline acne, you should be looking at symptoms and signs of hyperandrogenism.
Okay. Okay. And these are the tests which we shared earlier with our viewers that need to be done when we are considering hormonal acne as a diagnosis. And I would like to ask Satish,
yeah,
what is the time that you advise people the hormonal check? Any particular time of their cycle or any time when they come? Do you advise something?
You listed the entire several tests, and these are extremely expensive and not feasible in clinical practice. So I get only free testosterone done, and it has to be done in within the first 7 days of the cycle, on the onset of the cycle, and a fasting sample has to be taken. That's very important. Preferably on day 2 or day 3, maximum up to 1 week you can do a fasting sample. I don't do the entire panel of tests which you have mentioned. I do the most reliable one, which is the free testosterone.
Rahul, would you like to take that up as are you okay with that, doing only free testosterone, or is there something else which you would like to have in that panel as a
Generally, I personally prefer to go for a screening ultrasound before the test can be done, because with the help of the ultrasound and the clinical picture, based on the Rotterdam criteria for PCOS, you are able to make a diagnosis of PCOS in a good percentage of patients. But once that thing comes out to be positive, then I generally tend to go for a full battery of tests, because you never know where the axis is lost, whether it is at the level of maybe some of the patients with hypothyroidism may be having secondary PCOS. So when I go for these tests, I go for a full battery of tests. And apart from that, some people, especially in research settings, they have gone for anti-Mullerian hormone tests also. Personally, I don't.
I'm just coming to that, Rahul. I'm just coming to that. That's the role of anti-Mullerian hormone. Basically has been propounded by Dr. Kabir Sardana in Delhi, who's been one of the vocal proponents for getting the anti-Mullerian hormone testing done. So do you think, Rahul, it makes sense to get it done?
Theoretically, yes. As I said, maybe practically it hasn't found a lot of widespread usage as of now, but theoretically, yes, because it can be done for maybe adolescent girls also, where maybe transvaginal ultrasound sonography cannot be done for.
I think the point why Kabir has been stressing on anti-Mullerian hormone testing has been that ideally for the polycystic ovarian morphology, you need to do a transvaginal ultrasound. And when you have a relatively virgin women presenting to you, you may not be able to do a transvaginal ultrasound. And there you probably can use the AMH as a surrogate marker.
Correct.
Yeah, but we can't do that in all the patients because the cost factor is very important.
Yeah, cost is there. I agree with you, Satish, for all the tests for hormonal acne that are done. But the issue is that, as Rahul was pointing out, that to find out where wrong, and is it related to the adrenals or is it related to the other system, we probably need to do some of these tests to get a complete picture. Yeah, Rahul, you want to say something?
Yes, the same thing. So with just free testosterone, we will be able to just detect whether it is the what is the origin in a certain subset only. But with the others, as I said earlier, 17-alpha-hydroxyprogesterone or others, it's important to go for a full battery of tests once you decide that you have to investigate.
The commonest cause of hyperandrogenism in acne patients is PCOS. And it doesn't make sense to do a full battery of tests. That's what I feel.
All right, we will take up an audience question which we have from Dr. Mamta Patil, who said that I have a patient who is 21 years old and has moderate acne only since 2 months. And before that, she did not have any acne, and 2 weeks of doxycycline followed by 2 weeks of 10 milligram isotretnoin and topical benzoyl peroxide along with adapalene. But the patient is not responding. So what should be done further? So Dr. Udare, would you like to take that up? I think we've already have a cocktail of drugs here, it seems.
We have got everything. So now we'll have to again go, as I was telling, into the proper history. We'll have to take proper history, find out the cause, proper adherence schedule has been taken care of or not. That is another thing. And then basically, I would definitely like to do this battery of tests. I personally like to do testosterone. prolactin is another one thing. But then basically late onset adrenal hyperplasia is another one thing we should not forget. And DHEAS is another one thing I'll do. And as Dr. Rahul was saying, thyroid tests are also important in these cases. So I would go in this matter to see why she is not responding, and then hopefully we will get the results.
Yes, for 2 weeks, maybe too short a time for a significant response. So just maintaining
usually the patient sits on your head. Sir,
yes, I understand.
Well, we all know that androgen inhibition is a very effective strategy for treatment of acne in females, and we have the OCPs which are used since a long time now, and we have good fourth generation drugs which have very little androgenic activity like drospirenone. So I would like to ask my panelists here as to their experience with using the combined contraceptive pills.
My take, it is a wonderful drug. If you have got a female who's probably a PCOD, obese patient, this thing, a combination of contraceptive pills and metformin definitely works wonders.
Yes. Okay. And do you prefer to use the estrogen cyproterone combination, Dr. Udare, or do you prefer to use the drospirenone?
I love with cyproterone.
All right. Okay. Moving on, these are some of the OCPs which, Rahul, you want to say something?
Yes. So, I mean, this cyproterone is yes, it's quite favored, but maybe some of these ones, some of the new ones which contain drospirenone, like Yasmin or
they are also good.
They are quite good, and they avoid the side effects of your weight gain, etc.
Yeah.
So maybe some of the girls may be preferring that.
Yeah, I would like to say, in fact, that the combined oral contraceptives are beneficial for any women with acne who does not have a known contraindication to their use, irrespective, in fact, of their hormonal status. That's a point I'd like to highlight here before we move on. Any particular contraindications for combined oral contraceptives, Sanjay?
Yes, we have to take the history of especially there is some cardiac problems or hypertension, long-standing diabetes, any recent breastfeeding, 6 weeks breastfeeding, we can't give, and any embolism, breast cancer. So these history we must take. And what I do personally, always before starting any OCP, so I always take advice from my gynecologist friend, because ideally for medical legally, I think we should do that. Because these breast checkups and others is done by them. So I think that we are doing too. And after that, as you told, I do agree that is a very good drug. Even the hormonal imbalance, we are not directly finding, especially the acne, tarda, or late onset.
Sanjay, Sanjay, how do you ask your patients to start using the oral contraceptives? How do you ask your patients to start using them?
No, usually it is just after the cycle. Usually the method is next Sunday, so that even during the period it's ideal, because then we can exclude there is no pregnancy. But if it's immediately needed, some people require very urgent, then we have to do pregnancy test and then we can start. Usually,
I think I agree with you that probably the Sunday start method is probably a better way of doing it, because then you don't need to do a pregnancy test and you, precise. I think that's a good point that you made, Sanjay. Any experience of my panelists with spironolactone? Dr. Satish, would you like to?
Yeah. Nowadays, I am using more of spironolactone than oral contraceptives or the Diane, because it's a very safe drug, though it's not US FDA approved for treatment of acne. And it is an underutilized drug for by the dermatologists in hormonal acne. Because
and which doses do you prefer, Satish, actually? Do you use it at a higher dose, or do you use it at the lower dose?
I start with just 25 milligram. 25 milligram tablets are available. And after 2 weeks, I increase it to 50 milligram. And then if required, go up to 100 mg or maybe 150 milligram. I have not gone up more than that. And it's very safe unless the patient has any cardiac or renal problem. The hyperkalemia never occurs. The only problem I have encountered is there can be menstrual irregularities which may force the patient to stop the drug. If there is no menstrual irregularities, I think it's a wonderful drug, but you have to wait. The response takes about at least 6 weeks.
Okay, Rahul, your take on anti-androgens besides spironolactone, and do you recommend any of the anti-androgens, or do you think that just?
I never used flutamide or biclomide. No,
Yeah.
spironolactone.
Okay, all right. With that, we can move on to the last area that we would like to discuss today quickly, because we're running short of time now. Acne in pregnancy. Why exactly do we think we have this issue coming up? Dr. Udare, why do you think there are people whose acne tends to increase in that time?
There are a lot of hormonal changes are occurring at this stage. Basically, immunological hormones, weight gain, everything adds up in this stage. And once this thing, but then there are both things can happen in pregnancy. There are people, ladies I have seen who had severe acne, and once they become pregnant, they actually have improved. And there are patients who have never had acne and suddenly they get. So it's basically not one single thing. There is an interplay of a lot of things, but definitely hormones play a major role there.
Rahul, there is a question from the audience regarding spironolactone. I think it was directed at Satish. Somebody wants to know that would Dr. Satish give 25 milligram irrespective of age and weight?
No, you start off with 25 and then increase it to 50 milligram and go up to 150 milligram if required.
Okay. This is a treatment algorithm which is there for drugs which are beneficial for patients who are pregnant and have acne, and this was in the Journal of the American Board of Family Medicine in 2016 for the use of our viewers, and talks about the different drugs which are available for use in mild to moderate and moderate and fulminant acne. Going on to a quick talk about scarring in acne, we know the type of scarring which is there: ice pick, box scar, rolling, and hypertrophic. Sanjay, can I ask you, what do you think, is scarring limited to severe acne alone?
No, I don't believe. Acne can even, scarring can occur even in the mild form of acne. So it is, I told in the beginning that nowadays told the innate immunity, that's important, toll-like receptor 2. So that lead to the scarring. So even the mildest acne can have scarring, and even severe.
Right. But do you think the duration of acne is a factor which affects scarring as well, or the occurrence of scarring? The longer the acne.
We have seen cases only 6 weeks acne can cause scarring, and even 1 year acne has not caused scarring. But this is also is a genetic. But I think if we delay in treatment, if we start delayed treatment, a patient comes late, there is chances of scarring. That's important.
All right. So would my panelists generally agree, treat early and treat effectively, if not aggressively? Yes. Am I on the same page with my panelists?
Yes, we do. Yes, sure.
Okay. And coming to a couple of quick questions about counseling regarding, do you counsel your patients on choosing their daily care products, especially moisturizers, face washes, cleansers, and sunscreens? Dr. Udare, do you do that?
Yes, I do that, because basically patients are using anything and everything which is available and everything which is shown on TV. So considering that, we definitely have to tell them what is the thing, what they need according to their skin type, according to the oiliness present, according to the seborrhea present, what they should use. They can have a T-zone which is more oily, and if you keep on using this thing, they might get a lot of damage at the other areas. So we'll have to judge their skin, teach them what is their skin type, and then advise them accordingly.
Yeah. Sanjay, are you happy with triclosan-based moisturizers? This question I'm directing at you again because of our interest in contact exam.
Sanjeev, I don't recommend triclosan. Many of the companies' product, I ask them to remove triclosan, then only I can use it. Because you know, triclosan is our standard battery. So then, another point regarding this, your acne cleanser, I have seen lot of treatment failure in spite of good systemic and topical drug. That is, patient use wrong cosmetics, wrong soap, wrong cleanser. So it should be non-comedogenic product. That's a must. Because I've seen a lot of acne is not reducing only for using some cleanser or moisturizer that is comedogenic or sunscreen. So that we must correct
Dr.
in
Satish,
prescription.
Dr. Satish, your experience with the use of hair oils that patients come with, do you see this picture of acne on the forehead in people who use a lot of hair oil?
Exactly. I think acne is often associated with seborrhea capitis, and I always advise the patient not to apply oil and give a appropriate shampoo to use them at least 2 or 3 times in a week.
All right. Rahul, a quick word about sunscreens. Can you tell us something about sunscreens? Do you feel that they are required?
More or less they are required. I mean, because of many factors, because one of them could be because we are using a lot of retinoids as a first line therapy for our almost all of our patients, and to an extent it's going to cause some degree of erythema. And the second part is obviously post acne hyperpigmentation and scarring that may be exacerbated by your sun damage. So sunscreen should form a part of your daily routine care of acne management also. The
I think
point that
also with doxycycline we must use.
doxycycline,
Doxycycline photosensitive.
photosensitivities, yes.
Yeah, I have a couple of other quick questions on the role of nutraceuticals in the treatment of acne. Rahul, your take on that?
No, not at all. I mean, these are good for from perhaps non-academic point of view, but definitely not should not form a your routine part of your prescription because they don't have much of an evidence. Diet or nutraceuticals, they are still under research whether what sort of role they do have, but they should not form a routine silyramine, other antioxidants, not as a routine
All
prescription
right,
drug.
all right.
Take
Dr. Udare, I have a question
balance,
for you. Yeah, Dr. Udare
take a
wants to say
balanced
something.
diet. That is more important rather than following up the patient.
Yes. Low
Yeah, Dr.
glycemic
Udare, I have
diet.
a question
Diet.
for you. What's your take on truncal acne?
Basically, truncal acne is something which first thing I would like to tell everybody that your isotretnoin may not work as much as it works on the face. And then you'll have to be a little more persistent treating acne on the trunk. Third thing is that the basic sitting posture and all those things, whether there's a friction, all those things, those you'll have to do this thing. Fourth thing is that may not be triclosan, but basically you need some antiseptic soap to be used because the secondary infection usually sets in once there. And the last and most important thing is the scarring is very severe on this truncal acne. So you better, again, as we all agreed, faster treatment and complete treatment, antibiotics orally, local peeling agent and benzyl peroxide. This thing, benzyl peroxide washes work very well.
Yes, precisely. I think truncal acne is an under-recognized problem, and patients often fail to mention anything about their truncal acne. Plus, in addition, since we don't have specific guidelines, it's an ignored area. But I do believe that when people have facial acne, around 50% of them would tend to have truncal acne as well. And there is a very small subset which has only truncal acne. And truncal acne probably is a fit area for the consideration of retinoids as well, oral. When I'm talking about retinoids, I mean oral retinoids as well. Yeah.
But I think
Moving on quickly
systemic.
to experience. Yeah, Sanjay.
Sanjay, I think systemic antibiotic works more. There are certain papers on this. Then rather than systemic retinoids, I do prefer systemic antibiotic in case truncal, especially when it is alone.
If they're not responding well, then you consider pityriasis folliculitis for truncal acne.
Yes, that is a very common misdiagnosis.
Rahul,
very commonly misdiagnosed truncal acne.
Rahul, your take on
Again,
metformin.
yes.
Do you have something to say on the use of metformin
Yes,
for
again,
acne?
as Dr. Ghosh, I think in the first few minutes only he mentioned about metabolic syndrome, and it's increasing role in acne. So insulin resistance is, I think in our department also we had this important study in JAMA Dermatology where we showed that insulin resistance is has a very important role in male acne also. So metformin with its insulin sensitizing effect in a dose of maybe 500 to 1.5 grams, there have been studies which show that it can be helpful in management of acne. So definitely has a role.
Coming quickly to the end, last few slides, Sanjay, in the patient counseling, how important is ensuring compliance? Because I find that compliance is a very big issue, not only for acne, but in fact, all dermatologic
Yes.
conditions. And we always talk about compliance and adherence issues
Yes.
everywhere. You ask somebody to use a cream for 2 times in a day, he'll use it once a day or maybe once on alternate days. So how
Yes.
important for you is patient counseling, and do you think it forms one of the main areas in management of acne?
Yes, it is a, I think, first and foremost thing before starting any treatment, we should ensure compliance and we should explain and give some time for counseling the patient to continue, because most of the resistance nowadays we are getting with systemic antibiotic or topical, that's used to a misuse or irregular use or suddenly stopping the drugs. And you have to explain the patient that until you continue the course and until you ask the doctor, don't stop it. And also we have to tell about the patients, because some patients lose their patience and start different type of treatment, and also explaining about the total disease is very, very important, I think.
Okay, any lifestyle changes that you recommend, Sanjay? Because there is a question which I got from one of the viewers, and they've said that any lifestyle changes which you suggest for the patients,
Yes.
which have
Yes.
shown results in your patients.
Yes, yes, I do. Especially the younger generation, I tell them to do regular exercise, diet control, weight control. I tell all of them until you, otherwise the drug will not act. That I tell. And about this diet also, I stress that definitely they should take low glycemic diet, because that's nowadays showing that increased IGF, that insulin-like growth factor increases. So that I think very important part of our treatment, and I stress this to each and every patient.
Dr. Manas has asked a question. Rahul, can you take it up? He's asked, which is the safe OCP to be combined with spironolactone?
I mean, again, spironolactone, the thing is that although many times I prefer drospirenone based ones, but here with spironolactone, it's better not to combine with drospirenone, because both are, drospirenone is actually a spironolactone congener only. So there is a high risk of hyperkalemia if you are combining a drospirenone based OCP along with spironolactone. So
That's
here
a
you
very
would
good
use,
take-home message, actually. Yeah.
you would choose the cyproterone based OCP plus ethinyl
Yeah.
estradiol, low dose ethinyl estradiol plus spironolactone.
And I think to end today's webinar, what's new? Rahul, would you like to take that up?
Again, these are, androgen, basically, whether it is pubertal or it is late onset acne, acne has a very strong androgenic component to it. So this clastosterone, which is a topical anti-androgenic, it has shown very good promising results both in phase 3 trials also. So it decreases the inflammation, decreases the sebum production because of the inhibition of the androgenic receptors. And maybe the way forward could be this thing only.
And I think the other things that we are seeing are probably minocycline foam, which is being explored as a possible newer way of drug delivery. And with that, dear panelists, we come to the close.
0.3% is there.
Sanjay, just one or two points.
Yeah, quickly.
One
Yeah,
point.
Sanjay. Yeah.
Cyproterone acetate topical has shown promising results, and cyproterone acetate topical. And another is Ziluton, that is 5-lipoxygenase pathway inhibitors. That's shown good result in inflammatory acne used in asthma. So these are coming points. Yes, oral Ziluton.
Oral antihistamines like levocetirizine, desloratadine, because of anti-inflammatory effect, these have also been combined with isotretnoin. So new things are coming up.
Yeah. Yeah.
The only thing I'm worried about these new things is the cost and efficacy. It may not be going parallel.
And I think the discussion should not end without the last question on, do you think COVID actually alters the management of acne?
Basically, what I was worried about the isotretinoin part of it, because proper counseling for pregnancy and its effect on the pregnancy. These are the one thing, should be there, the pregnancy test if you ask whether the patient has done or not. and proper counseling, whether I'll be talking too much to the patients this thing, because again, Dr. Sanjay said counseling is most important. So these are the things what we are probably lacking doing telecommunication and during COVID area.
So one last comment on this, please. So ICMR has some guidelines for telemedicine also, and they have given a very not, I'll say, not even a basic list of drugs which can be prescribed. Maybe it's a changing thing, but that doesn't figure a lot of oral antibiotics and oral anti-acne therapy.
I think I would like to end the webinar here with the observation that in the current COVID setting, it is left up to the individual doctor to go through the current guidelines as put up by the national agencies from time to time, and see if there are any specific recommendations for the use of some type of tests or treatments. When you are dealing with drugs like steroids and immunosuppressants, it's a different ballgame altogether. But I think for topicals, probably there is no issue involved at all. And with that, I would like to take this opportunity to thank all my panelists for a wonderful discussion that we have had today evening. And Sanjay, Dr. Udare, Dr. Satish, and Rahul, it's been wonderful having you here on the panel. It's been my pleasure. Thank you so much, and good night.
Good night.
Thank you.
Thank you, sir. Thank you so much.
Sanjay.
Thank you, Dr. Handa. Thank you, Dr. Ghosh, Dr. Udare, Dr. Satish, and Dr. Rahul Mahajan. Brinton as an organization would always be in forefront of disseminating medical and scientific information to the medical fraternity in India. It was our pleasure to have you all with us today. And on behalf of Brinton, I also thank the attendees who are present and attending this completely scientific and medical session. Thank you so much.